defining situation with pneumonia is that you have infection of the alveoli, and that causes consolidation. So that is where the air that's in the alveoli has been replaced by an inflammatory exudate, bacteria, white blood cells, and red cells, replacing the air. And you can see that on the chest x-ray. So for example, this chest x-ray shows somebody with a right upper lobe pneumonia, and there's a white patch over the right hand of the lung, and that reflects the dense consolidation that's occurring in that area, and there's no air left in those alveoli. And this distribution of pneumonia is a lobar pneumonia. It's affecting one lobe only, and the rest of the lungs are clear. And that's the commonest presentation of an acute pneumonia. You can get pneumonia which is patchy throughout both lungs. So little patches throughout both lungs. And that's called bronchopneumonia, and this is an example of that. This is a much more serious disease in general, because that's a very extensive infection and is often a fatal event in patients with underlying severe disease such as a cancer or another disability such as dementia or a chronic neurological deficit of some description. A third pattern of pneumonia that we can see is an interstitial pneumonia. Now, you probably can't tell very easily on this chest x-ray that it's abnormal, but there is a widespread reticular nodular infiltrate in both lungs, but it's very subtle. And that represents, again, a diffuse pneumonia and is commonly associated with the atypical organisms that I mentioned earlier, Mycoplasma and Chlamydia. The overall importance here is that if you have pneumonia, there is some form of alveolar consolidation, usually lobar, but potentially interstitial or bronchopneumonia as well. And we can detect that clinically. So if you have somebody with pneumonia, the area of infected lung, the area of consolidation, will be dull to percussion, and when you listen to it, there will be crackles in that area and potentially bronchial breathing. And the chest x-ray, as we've seen, is obviously abnormal. It shows airspace shadowing with white patches in the affected area, and occasionally what we call air bronchograms. That's where the bronchus that's moving through the consolidated lung has been delineated by the alveolar consolidation either side of it, so it shows up as a black tube going through a consolidated area. So, pneumonia is classified into different types. And the first and the most important, and the subject of most of this talk today, is community-acquired pneumonia. And that is what it says in its name. It's a pneumonia that is acquired when you're living at home and not in hospital or anything else. So it's the normal standard pneumonia that you pick up in your everyday life. There's a subcategory of community-acquired pneumonia called healthcare-associated pneumonia, which has been defined recently in America, but probably is not relevant in Europe. And I'm not going to discuss that in any more detail today. That is a pneumonia that occurs in people who are in long-term care facilities, nursing homes, etc. But in fact, in Europe, it's probably not that much different to normal community-acquired pneumonia. And therefore, we group it with community-acquired pneumonia. The other important forms of pneumonia are hospital-acquired, which, as it says, is a pneumonia that you develop when you're in hospital. So you're admitted to hospital for another reason, say you're having an operation, and then after the operation you develop a pneumonia. That would be a hospital-acquired pneumonia. It's also those patients who've been in hospital recently and then come back in with a pneumonia, because the organisms that are causing that pneumonia have probably been acquired whilst they were in hospital previously. They are also defined as hospital-acquired pneumonia. A third form of pneumonia is ventilator-acquired. That's basically a subtype of hospital-acquired pneumonia, but it means that this is pneumonia in patients who are on the intensive care unit being ventilated with an endotracheal tube inserted. And they are susceptible to pneumonia because the ET tube, the endotracheal tube, bypasses quite a lot of the normal immune mechanisms for preventing infection. And the last category is immunocompromised host. These are patients who have a very severe defect of their immune system, and that allows a range of unusual organisms, bacteria, viruses, and fungi to cause the pneumonia. So the chance of having a pneumonia to an unusual organism is much higher in these patients. But we're talking about patients who have severe immunocompromised state. So those who've had chemotherapy for cancer, those with HIV infection with poor CD4 counts, those who had transplantation of their marrow or a kidney or their lung, etc. So patients really with very severe immune defects. So, who gets pneumonia? Well, there's an easy answer to that question, and that is absolutely everybody could get pneumonia. It's not uncommon in young people, but it is particularly common in two age groups. The very young, the under fives, and as I mentioned before, it's the commonest cause of death across the developing world in the under fives, and the elderly. And there's an almost exponential increase in the chance of developing pneumonia after the age of 65. So it ends up that the chance of developing pneumonia in somebody who's very old, over 85, is about 5% a year. The risk factors for pneumonia also, as well as age, include previous influenza or other viral infections, because, as I mentioned in the influenza lecture, a viral infection of the respiratory tract affects the immune response to bacteria and allows bacterial infection to develop as a consequence of the viral infection. So secondary bacterial pneumonias after influenza are very common, and that's the major way by which death is caused during the pandemics, or has been in the past. For example, the post-World War I pandemic, which killed 20 million people. Most people died of pneumococcal and staphylococcus pneumonia after having the influenza virus infection. Other people who are more susceptible to pneumonia are alcoholics, or people with liver cirrhosis, because that affects the ability of the immune system to fight bacteria. Smokers, that allows the bacteria to establish infection in the lungs more readily. Actually, having had one episode of pneumonia makes you 2 or 3 times more likely to have another episode. It marks you out as somebody susceptible to pneumonia. And then patients with chronic disease, chronic lung disease, COPD, for example, chronic neurological disease, dementia, previous stroke, etc., any renal impairment or cardiac failure. These are all reasons why these all increase the chance of getting community-acquired pneumonia. Now, if you have hospital-acquired pneumonia, you need to be in hospital. So if you're hospitalized for a reason, then you're at risk of hospital-acquired pneumonia. And if you're ventilated, then you're at risk of ventilator-acquired pneumonia. And the risk of that is about 1% per day that you are ventilated. And then, of course, the patients who have immunosuppressed for their treatment of their cancer or because they've had a lung transplantation, etc., those will be at risk of pneumonia of the immunosuppressed patient. What are the symptoms of pneumonia? Well, actually, they're very straightforward. You have the systemic symptoms that you get with infection: fever, feeling unwell, occasionally you get the shakes, the rigors, and you're not eating, and you feel terrible, and you want to go to bed. Then there are the focal symptoms you get because it's a lung infection, and that will be cough, producing a purulent sputum sometimes. Sometimes you get blood in that as well, and the mixture of purulent sputum with blood becomes what we call rusty sputum, a sort of browny colour sputum. You may get pleuritic chest pain if the pneumonia is causing overlying pleuritic inflammation. That's called pleurisy. And because the pneumonia consolidation is affecting the ability of gas exchange in your lung, then you might be breathless as well. When you look at the patient and examine them, again, you have the general examination findings of somebody with an acute infection, pyrexia, they don't look very well, they may have they should have a tachycardia, and they have an increased respiratory rate because of the problem with the consolidation. There are a few other issues. They may have herpes labialis, so herpes simplex infection around the mouth actually often reactivates during people with pneumonia. And if they have significant hypoxia, then they'll have central cyanosis. And pneumonia is a relatively common cause of acute septic shock, so they might have hypertension as well. And occasionally patients have atrial fibrillation because acute lung infections are one cause of temporary atrial fibrillation. So that's the general examination. When you listen to the lung, we've already mentioned the signs, which essentially is focal asymmetrical crackles, crepitations over the areas of consolidation. If it's really dense consolidation, it'll be dull to percussion, and there'll be bronchial breathing as well. And about a third of patients with pneumonia will have a small effusion, and some of those will have a pleural rub. So if somebody presents with pleuritic chest pain because of the pneumonia, the pleurisy, it's quite likely that there'll be a pleural rub over the area where they feel the pain. Now, if you're trying to work out whether somebody has a pneumonia or an acute tracheobronchitis, and this is a very important distinguishing situation because tracheobronchitis is a relatively benign disease and will settle, whereas pneumonia does have the potential chance of becoming a very severe disease. Then there are a few of these signs which are important. So, for example, you will not get crackles if somebody has a tracheobronchitis. And so the focal lung signs that you get in pneumonia are not present if somebody has a bronchitis. In the general examination, if you have an acute tracheobronchitis, it doesn't cause impairment of respiratory function to a significant degree unless you have an underlying lung disease. And so in the normal patient, there shouldn't be an increased respiratory rate. They should not get cyanosis. And it should never get severe enough to cause hypertension or a particularly high pulse rate. So what are the principles of management of somebody who's presenting with what seems to be a community-acquired pneumonia? Well, first of all, you need to confirm the diagnosis. Then you need to assess the severity, and then you need to think about treatment. And that has three main components to it. Correct the oxygenation, because that's the risk for mortality. Treat the fluid balance. Again, hypotension is a risk for the patient. And three, clearly, it's an infection, and you need to kill the pathogen, and that's going to require antibiotics. And then you need to monitor to make sure that the patient's improving with whatever management you've instigated. So to take these in turn, confirming the diagnosis, essentially that's a chest x-ray. You think the patient has some crackles over the right lung and they're presenting with a fever, then you need to know whether there's consolidation present. So do a chest x-ray and it might show lobar consolidation as is shown here in the right lower lobe in this chest x-ray. It's also very important to do a chest x-ray to look for complications, and we'll discuss some of those later in this talk, but we're talking largely about pleural effusion. And there may be related pathologies. So for example, if you have a lung tumour which is blocking a bronchus, then you'll get pneumonia distal to that obstruction quite easily. So a chest x-ray might help identify patients who have coexistent pathology which is relevant, such as a lung cancer. And also, it will help confirm that there isn't another diagnosis present and that you've been fooled and this is not your pneumonia. For example, pulmonary edema, etc. Sometimes you might need to do more extensive radiological investigations, such as a CT thorax or a CT pulmonary angiogram, but that's unusual. And if you're really worried about heart disease, then you're going to need to do an ECG echocardiogram. Now, blood tests are quite useful in patients with pneumonia because there is a certain abnormalities that may show up. For example, if somebody's got an acute infection, you might expect the white cell count to go high, to be raised as an inflammatory response. That's true. It happens a lot in pneumonia, but also a low white cell count is also characteristic of infection in these patients as well. The urea and electrolytes can show significant abnormalities, commonly a raised urea and a raised creatinine due to a degree of acute kidney injury. And often patients have a low sodium as well, a hyponatremia. Liver function tests often are abnormal in patients with pneumonia, a high ALT and a high alkaline phosphatase, and the albumin is one of those markers of acute infection. So for example, somebody gets acute pneumococcal pneumonia, their albumin may drop from its normal range of about 40 down to 25 very quickly. So hypoalbuminemia is a marker of infection. Possibly the most important blood test is the C-reactive protein. This is a marker of inflammation. So if you have pneumonia, it's infection, there should be a very significant inflammatory response. So the C-reactive protein, which is normally less than 5, goes up very rapidly in most patients with pneumonia. So if you have a C-reactive protein which has not gone above 40, you might want to think about the diagnosis in a bit more detail because it may not be pneumonia. In fact, it's not uncommon for it to be above 100, 200, and even 500 or 600 in patients with acute pneumonia. The other blood tests we need to do are tests for oxygenation, which I'll discuss later, and there are some blood tests which are tests for potential infecting pathogens, which I'll also discuss later. So, what's the differential diagnosis of somebody presenting with what you might think is community-acquired pneumonia? Well, we actually mentioned already acute bronchitis, influenza bronchitis are two of the main differential diagnoses. The important thing there is they do not normally have evidence consolidation. If you have evidence consolidation either clinically or on X-ray, then that means the patient has a pneumonia rather than just a simple acute tracheobronchitis.